Continue with the care measures such as use of masks, hand washing, and isolation of people with respiratory conditions. Remember that in areas where there's more concentration of people, there's an increase in the risk of being infected with COVID-19 and other respiratory virus. Therefore, it is important to wear a mask and ventilate the rooms when we are in closed environments. To prevent the influenza or seasonal flu, we need a vaccine, and realize that the RSV attacks children and the elderly. Therefore, the protection measures against COVID-19 also protect against the disease. We should wear masks, hand washing, and ventilation of the rooms. In relation to the current situation of avian flu, we recommend to avoid a contact with wild birds and to report to the health services or animal health services. And we would like to highlight the importance of solidarity and respect for people. Well, in accordance of the above, today, Tuesday, December 13, we open our virtual doors to discuss a topic of great importance for our region with webinar number 153 entitled Update on COVID-19 and Avian Flu. We invite you to leave your name, organization, and country from which you are joining us through the comment box of the Facebook Live or YouTube Live chat. In this same space, you can leave your questions or send them via email to webinarscorascondu@gmail.com. To access the certificate of attendance to this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook Live or YouTube Live chats. The certificate will be sent to your email in the next few days. This webinar will be developed with the usual dynamics. We will start with the institutional greeting, then the dissertation of our speaker, and then the Q&A session. To begin this important day, I give the floor to Dr. María del Carmen Calle, Executive Secretary of Horas Condu, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Thank you, Lucho. Well, in the context of the current COVID-19 pandemic, international research and expert opinion raise the importance of conducting all-cause mortality surveillance mortality is a reliable and comprehensive way to measure the overall impact of COVID-19 mortality. It allows national authorities to better assess the burden of COVID-19 without relying exclusively on molecular testing. To reduce the gap in the report of deceased persons, the National Computerized System of Death, SINADEF, was created in Peru in December 2013, which has a computer application that allows the entry of data of deceased persons, fetal death, and identify persons, as well as a generation of the death certificate and the statistical reports. Today, SINADEF needs to recover in order to continue fulfilling its mission of providing critical information on death caused by communicable and non-communicable diseases and other causes, such as those caused by traffic accidents and violence. And in order to continue fulfilling its important role, it is necessary to make the necessary agreements to provide it with the security procedures that will allow it to fulfill the role for which it was created. A second topic that we are going to address today is related to the outbreak of highly pathogenic avian influenza, H5, that is occurring worldwide. Influenza A virus, since its identification in 1996, has had multiple waves of intercontinental transmission of H5N6 lineage virus, the same virus that has resulted in the death and mass culling of more than 316 million poultry worldwide between 2005 and 2021. From November 2021 to August of 2022, more than 22 million cases of avian influenza were reported in wild birds and poultry in 68 countries. And to control the outbreak, 92 million birds have been sacrificed. Currently, in the last quarter of 2022, there have been outbreaks of avian influenza in wild birds and control outbreaks in backyard birds in Colombia, Ecuador, and Peru. In the case of Peru, Franklin's gulls are suspected when passing on the route from the US to the Patagonia, and in the case of Colombia, the migrant duck, the spatula discourse, is involved. Humans 850 cases reported, of which have died, showing that over the years, avian influenza in humans has occurred in people who have had direct contact with birds or their remains. To learn in detail about these problems, we have invited Dr. Eduardo Gotuso, to whom we extend our warmest welcome. We know that Dr. Juan Luis Iribarren is unavailable and he will be able to join us. Welcome. Thank you, Lucho. Very kind. After the institutional greeting, my name is Luis Bengolea Mori, medical epidemiologist, coordination of border health and thematic areas, and I am pleased to be in charge of moderating this webinar. We will start this event. Welcome, Dr. Eduardo Gotuso Herencia. Dr. Gotuso is a surgeon, master in medicine, Peruvian University Cayetano Heredia, specialist in infectious diseases and internal medicine. He directs several projects with international support that allowed dozens of young students to do research. He was the first Peruvian to be the president of the International Society of Infectious Diseases. He is an adjunct professor of the William J. Harrington Training Program for Latin America of the University of Miami, of the International Health Department of the Johns Hopkins University, and the Department of Medicine of the University of Alabama in Birmingham, USA. He's an honorary member and advisor of multiple international academic associations, has 532 articles published in Peruvian and international journals, and participated in the development of 47 chapters in different books in Peru, Latin America, US, in UK, and has published 2 books and 6 manuals. He has been head of the Department of Infectious and Tropical Diseases of the Cayetano Heredia Hospital and director of the Alexander von Humboldt Institute of Tropical Medicine. Today, he is Professor Emeritus of the Cayetano Heredia University and Senior Professor of the Faculty of Medicine of the university. Welcome, dear Dr. Eduardo Gotuso. You have the floor to present topic of should we continue being vaccinated and avian flu. Thank you, Dr. Bengolea. Thank you, Dr. María Carmen Calle, who has made an excellent summary of what is the current situation. This meeting had a first presentation from Dr. Juan Luis Iribarren that due to health problems, he had to postpone his presentation. I would only just like to emphasize that for the last 2 years, we have an approach where he was being one of the promoters of why it is important what Dr. Calle mentioned of SINADEF, this national system for deaths. And let me tell you that there was an important emphasis when in Peru, the head of a surveillance system spoke that there were 300 deaths in the Amazon, and the head of the region at that moment said that they had 900 people that had died. So there was a clear dissociation that for a long time, received many criticisms, people that were hiding information. And actually, it was that the reporting systems were extremely complex and slow, but the only system that we have in Peru that's extremely good, and that when somebody dies in Peru, in the following 24 hours, it has been electronically registered, even in the most remote area of Peru or the capital city of Peru. This system allows us to have a count of what we call the deaths, the average death per year. So 10,000 deaths per year. But the excess of deaths that Dr. Calle mentioned is extremely important because that excess death may be due to an earthquake or any other condition. But at the time of the pandemic, the important factor was the pandemic itself. Peru had the courage of deciding that these excess deaths that we had represented people died because of the pandemic, and that's why Peru was the country that had the highest mortality in the world. Very few countries have done that calculation of recognizing there's excess of death that are not well recognized and are not in the files. So that death excess is an important criterion. And the advantage is that that excess allows us to identify where the people dying, what their age is, so we could organize an active program on where to vaccinate, who should be vaccinated, where to put their respiratory equipment. So this is an instrument that has an enormous value and that clearly Dr. Irribaren, because this is a public, the results of SINADEF are public. Anybody can go and look, and this is what Dr. Irribaren did, that will allow to have an immediate picture of what happened 2 days ago, how many people died, which it doesn't mean that the Peru CDC still doing monitoring surveillance because they have more information. But the SINADEF doesn't exclude, they're not mutually exclusive. The advantage of SINADEF, and unfortunately, because of a reason that was completely negative, because somebody hacked the system and issued a death certificate of two politicians, and SINADEF lost faith, and there was an incorrect decision because that should be solved immediately. And we are on the crusade that SINADEF for today and for any pandemic is an excellent method to monitor mortality. That is why I wanted to take these minutes, because at some moment, Dr. Irribaren may explain with very clear data what had happened. Now, with part of the information on my conference about COVID is related to that. So I would like to close this topic with a professional and technical opinion that the Ministry of Health and RENIEC have to come to an agreement so SINADEF is reactivated immediately. because we must remember that when we talk about COVID, the pandemic is not over. It's still here. It's late in some countries, but I would like to remind all of you that Spain has ended their sixth wave, and in Germany, they're going on seventh wave. So, in addition, that we not only have COVID and we have influenza and we have other diseases, we cannot lose the focus that we need to have a better grip on that situation. And one of the ways is to know how many people are infected, how many are in the UCI, and how many are dying. Many people die in their homes because in our cultures, in the Andean countries, many people don't want to go to the hospital. They believe that a hospital is a place where you're going to die anyway, or the patient is admitted, the family cannot visit their member, you're not in contact, the patient dies, and 7 days later you find out that patient has died. So that has resulted that the population is fear to go to the hospital. So many people that die, we don't know exactly what the number is. So that excess death is important. And also the analysis with relation to the CDC in Peru and in each country with these surveillance systems. This is extremely useful because many people say, well, the vaccine is over. Why to get vaccinated doesn't make any sense. That's not true. That's not correct. And I think that we should look at these conditions rather clearly. And now I'm going to share my screen. Let's see. I would like to share the screen, please. Yes, go ahead.
Perfecto. No sé si está viendo mi primera diapositiva.
Can you see my first slide? Yes. So, an everyday question. Well, why should we continue being vaccinated? The COVID is gone. I think that's a very first mistake. Since the first time that there was a publication made by the Chinese group, it clearly showed who were dying. Death in a time when there was no vaccine, there was no treatment. When the British did the same, they recognized two things: that men died more than women, and the important ages started 60 and over. So this is something clear that I think that in Peru, following the first wave, the first reported by the national program, that more men died than women. And there's several reasons for that. But in Peru, surprisingly, the cutoff point is somewhat lower, not on 60 years. Mortality also affected groups, younger groups. And this is what we saw after the second wave. This data, thanks publicly available information, we clearly see that in the first wave, we see that over the age of 60, then we see the economically active population, and then we see the adolescents, and finally children who with hardly any death. The second wave, the values are above in the excess of death. In the second wave, there were more people dying, and most of them were over the age of 60. But you see that the economically active adults also died in a higher number. And here we had vaccines. I'm talking about September of 2021, where part of the population had been vaccinated. And surprisingly, the adolescents also start to show in an increasing number of deaths. This is clear, and you can see this through the synergy systems. So we start with vaccination. It's important that we acknowledge. It's, I don't understand how we have colleagues that are against the vaccination when the vaccination of any disease has four effects: decreases morbidity, reduces mortality, improves the activity, and reduce the global financial burden. Now, when you look at vaccines, under normal situations, the vaccines have to follow a system of research with preclinical trials, with animal studies, then the clinical trials, followed by the manufacturing, and they are frozen and distributed, and finally we start the vaccination. With any vaccine, it may take 8 to 10 years, but in the pandemic, fortunately, one of the major things that we've seen that during the pandemic, we had the vaccines available. So although in Latin America, we always talk about three or four, WHO and the EMA, which is a European Union medical group, recognizes all these vaccines as useful. And this is an important concept because many people believe that only Pfizer or Moderna are the only ones recognized and approved. All these vaccines that you see in this list have been approved by WHO under emergency conditions. Now, the vaccines against COVID, some special characteristics as opposed to some other vaccines. When you vaccinate against hepatitis, you know it's going to last your whole life. Yellow fever lasts because these are rather stable viruses, and our antibodies can last the entire life for that type of virus. However, there are some considerations such as influenza, where the virus changes after year. And in this case, this virus had significant mutations that I'm going to share with you later. So the new vaccines didn't have the old goal of saying we will provide the vaccines and protect everyone in a significant manner. And that created a lot of problems of trust. So the first goal was to reduce mortality and the severe disease and hospitalization. But we didn't know if that reduced transmission. To study that, you require 2 or 3 years, while providing a vaccine during the first year was extremely important. Secondly, because we're going to vaccinate a lot of people, there's always some risk of some occasional adverse effect. But what you have to put in the balance is what is the trade-off of reducing hospitalizations and death compared to a health system that was completely fractionated and weakened, that has also produced an economic crisis worldwide where the Latin American countries have suffered. We have not only lost life expectancy to 2 to 4 years following the pandemic, but our economy has deteriorated significantly. Therefore, when you vaccinate, you reduce those complications. Of course, this is a complex and new situation. There were like 6 vaccines, and each one had been studied with 2 doses, with 1 dose, with 2 doses, with 3 weeks apart or 4 weeks apart. That was frozen at -70, others frozen -20, others are 4 degrees. So the cold chains and the standards for one disease had this complex situation. So the what defines an efficacious vaccine? We can measure it if it prevents disease, with prevents hospitalization, prevents intensive care admission, or prevents death, or prevents transmission. Each one of these questions are asked and are significant. Here I would like to mention as an early study that was remarkable, but was not received the emphasis because there was a lot of politics involved because of the Chinese vaccine, if it was bought by that president. So there was a negative situation against the vaccines because there was some medical staff that also got ill and some of them died. So that affected trust. And these are important data, as we can see in the slide. This is health staff that did not vaccinated, that rejected the vaccine. You see the number of deaths grew day after day. Those who received one single dose had a lower mortality, but those who received the two Sinopharm vaccines had a remarkable reduction of mortality. So this is a critical study that at that time there was a lot of misinformation against this group that did a very good work. And we see the group that had infections was reduced, mortality was reduced, and the COVID-19 mortality also was reduced. So three elements in the health staff. This was a remarkable achievement, but the criticism came, these are data that are not reliable. These were honorable people who provide sound information. Now, let me mention to you a situation that Dr. Rivare was assisting. Death when the from March 2020 to October 21 in over the age of 60. As you can see, this is the number of death. So 1 out of 30 elderly died, but when you stratify by 10 years, 1 out of 14 over the age of 14 died. So the impact was extremely significant in this age population that went to the hospitals and was admitted to the ICU and unfortunately died. But when you look at this curve, what do you see in 2021? This is January, February, the first wave, and then it starts to decrease in a remarkable way. What happened here? We start the vaccination in Peru. And this is not an international study. This is a study in Peru with data from death where we clearly see that the large impact of the vaccine. We were able to calculate how many people in 1 month were saved because of the vaccine. Non-vaccinated, we had 600,000 and we had 3.5 million vaccinated. How many people got COVID on that month? 293. And in this group, so the mortality rate per 100,000, it was 8.6 here, and it was 48. So 6 times higher. So how many people would have died in October with no vaccines? 1,700. How many died? 303. So we saved 1,400 people because they were vaccinated. So it emphasized the extreme value of being vaccinated. We're talking about October 2021. When we look at the hospitalization and the use of the health systems, the non-vaccinated, 1 dose, 2 dose, that is the number of people who recover in green, and in red or brown, those who died in the hospital. So there was clearly that the health system improved with vaccinated and we could discharge people. This didn't mean that this was perfect, but there was a significant improvement. And it has been also remarkable, especially in Peru, in pregnant women. In pregnant women, we discussed at the beginning with Dr. Munaiko that we were concerned that there were many young girls, healthy girls, that had a premature delivery and ended up on a respirator. So we were following the number of pregnant women, and these women, so there was a very high number in Peru. You can see this US population of almost 400,000 symptomatic women with COVID. When they analyzed women by age, race, but comparing with pregnant and non-pregnant women, what do they find? more UC admission, more mechanical ventilation, more use of ECMO, and more mortality in pregnant women. In addition, that there was a higher risk of premature delivery. So these were five remarkable conditions that came later of what had been observed in Peru. Surprisingly, all the studies always exclude pregnant women, but Israel was the first country, and that's why I'm using this picture. These women in Tel Aviv was vaccinated when there was no approval. Only four countries had approved it throughout the world. So Peru reported one of the highest rates of mortality in pregnant and in immediate after delivery. The Peruvian Society of Gynecology and Obstetrics took a courageous decision. At that moment, they decided we need to vaccinate. We should vaccinate pregnant, although there's not enough information. Many young women are dying. So Peru had this data, number of women with a progressive increase of mortality and excess of maternal death. So maternal deaths were growing significantly associated to these conditions. What did we find? The start of vaccination. Peru was one of the five countries in the world that started vaccinating. And what was the effect? As of October, in only 5 months, there were no maternal deaths associated to COVID in pregnant women. So this decision was extremely important, despite that there was not sufficient information. We balanced the benefit and risk. And that is why today there are several considerations from Dr. Antonio Ciudad, who said that COVID-19 increases the risk in pregnant women. Vaccinated protects for severe COVID-19 disease. We recommend to vaccinate all pregnant women. And the most important that we know is that the newborns of mothers who were vaccinated in the first 6 months are protected compared to children who are born of mothers that were not vaccinated, and that there's no fetal injuries. These are the considerations that I would say are the most important to consider to accept. And now we're going to see that some oncologists say that we should not vaccinate our patients because they don't respond adequately to vaccines. However, there are several studies, and I would like to present to you this one, how we see a protection. It is true that the hematological malignancies have a poor response of efficacy, but not safety. Remember that vaccines are not attenuated live viruses. The COVID-19 are fragments obtained from the viruses, but these are not live viruses. So look at the solid tumors. There's a reduction in risk of 66%, and the risk when you're receiving chemotherapy, the risk is higher when you are approaching the time of chemo. But when you finish the chemo, the risk is more productive in terms of protection. So patients with cancer should be vaccinated. The answer is yes. Same as the patients with dialysis, because these are groups that, although the response is poor, but they require more dose, but we should not stop vaccinating these patients. The only ones that cannot receive vaccine when they have a bone marrow transplant and are in the initial phase of chemotherapy, we have to wait 3 or 4 months. But the rest of oncological patients should receive their vaccination, and the answer is yes. And this has been seen in several studies. Bone marrow transplant, organ transplant, they should be protected despite the immunological dysfunction due to cancer or transplant or the drugs for rejection. anti-rejection, they should benefit from a vaccine and they should not be excluded because it's not the same to administer a live attenuated vaccine because they may have a disseminated case of the disease. But this is a different story. Now, the next question that responds why we need to continue vaccination is this one. There are viruses that are very stable. For example, hepatitis or yellow fever. They're quite stable, and therefore, when you generate antibodies, they can last year after year. You may be protected your entire life. But the mutations occur in all viruses, but these are mutations that are not important because they don't increase pathogenicity. For example, 2 to 4 mutants appear in clones. What it is important is to see if the new variants infect more people or produce more hospitalizations. And this is what we have seen with the new variants before having the vaccines. The other thing that is important in the first model was when AstraZeneca presented the results of the vaccine, where there was a 90.5% protection in the UK, but larger studies in South Africa, and only 62% were protected. So they thought it was a problem with the dose, and there was no compliance. But sometime later, we understood that there was a variant in South Africa that was a new one and made the vaccine efficacy significantly reduced. Then we saw the Delta variant in India as a responsible for the second wave, where it will infect it more and produce more admissions and more death. That is why when we're looking for variants, the first question is there an increase in transmission? Is there an increase in severity? There's a reduce of efficacy of the medical treatment or vaccines? These are the three questions that we always ask ourselves. In Germany, they did this schedule. The first variant, first wave, 2021 is first, and then the first alpha variant, and then the delta, and then the omicron at the start of 2022. And this is remarkable because the number of deaths change. In Germany, the mortality risk changes depending on the variant, and this started to be modified because of the use of vaccines. But the variants had that special considerations. In addition, this is a CDC publication from the US where I would like to comment because many people say, no, I'm going to want Pfizer, I don't want any other vaccine. When this retrospective study made by the CDC, they recognized that the efficacy of vaccine against the variants was not 99%, it was somewhat lower. However, Moderna has better results than Pfizer for this variant. And this is important because it is in less than 20, the 75 is 89%. And I mentioned this because many people said, well, if I don't get Pfizer, I don't want any vaccine. And that is a significant historical mistake because I'm going to demonstrate how all the vaccines were quite efficacious. And then we saw the emergence of Omicron in November of last year. They found that it's high transmission. And the second thing that we saw that didn't happen before, that people may have twice an infection by the same Omicron variant. As you remember in the first wave in 2020, those who had COVID didn't get it again in the following 12 months. But with Omicron, it's a different story. Surprisingly, despite a high transmission, the clinical severity is much less, especially in those vaccinated. This is important because in 6 months, 85% of the countries were had Omicron present, so this is a significant situation. And the CDC in January of this year issued new information. The protection drops when there are two doses, and when there's a third dose, it increases. So the third dose in January of this year had significant information. And the booster, it was so important. The patient who's not vaccinated has 5 times the chance of becoming infected. But in those over the age of 65 with adequate vaccination and boosters, they have 50 times less risk to be hospitalized. Now we're talking to hospitalize and having a crisis produces a serious problem. There's no COVID, the diabetes, cancer, AIDS, and to treat hypertension, all of that was marginated because of the effort of treating hospitalized patients with COVID. So it was important that these people that were going to die have 50 times less risk of, when vaccinated. The third important thing is that the house contacts with Omicron was much higher. That is why we saw how you can diagnose one case and then diagnose several other people. Now we know that when you become infected and you have the vaccine, both have the same viral load on the first day, but the non-vaccinated can have virus circulating up to 7 days later, while those vaccinated patients on day 5, almost no one has active virus. So there's a reduction of transmission and reduces significantly reduction of the viral load. So now in 2022, we see more and more variants and more cases with high transmissibility, and we recognize that you can be infected in a few weeks. Some patients in less than 3 months have a second episode with the same virus, and that the vaccines in some cases lose some efficacy. However, we insist in these variants. And what's the difference? Remember that the vaccines, the Wuhan virus, but with the emergence of the beta, alpha, some of these variants have been reported by the National Institute of Health of Peru, by Dr. Sukayama and Cayetano, but we start to see Delta, which was the second significant wave, but then we have Omicron, and we start to see subvariants. As you really can see, this virus is quite different to this one. So that is why these are not brothers, these are second degree cousins or third degree cousins. So we need to continue vaccination, but it is very likely, as we've seen in developed countries, that they are producing bivalent vaccines with Omicron, with Delta, in order to cover this situation. And that is going to be important that the high risk groups can receive this type of vaccines soon in our country, because these vaccines are continue to be more active and better. What we know now is that the antibodies generated by the vaccines we manufacture 6 to 8 months later, the antibodies are significantly reduced. So the population requires a third dose. The answer is yes. Can we mix different type of vaccines? At this moment, the fourth dose is still under debate in some areas for people that are not at risk. There is no discussion, and all the people at risk, starting those 60 years old or greater, and all those under the age of 60 with some risk factor should receive the fourth dose. And the answer is yes. That is why many countries, all their staff, health staff has received the fourth dose. But in our countries, we don't have the entire population with 3 doses. That is why I insist that you can use several vaccines. This is a study in The Economist. How many people were saved to December of 2021? AstraZeneca 7 million, Pfizer 7 million, Sinovac in many Asian countries in Chile, Sinopharm, Sputnik in Argentina and Venezuela. All these reduced mortality according to there was a clear response that they all had a significant efficacy in reducing death. Chile, for example, Chile vaccinated many patients with Sinovac up to 91% of vaccination. 2 million received other vaccines. But when they used the third dose, they used AstraZeneca, Pfizer, and Sinovac. All of them had a protection over 80% protection. So the third dose may be done with any vaccine. What did we see in Argentina? They used the Sputnik from Russia and AstraZeneca for the first two doses. However, the third dose, they had several vaccines. They had Pfizer, AstraZeneca, or Sinopharm. And the three vaccines with the third dose, with any of these vaccines, was useful, and the reduction of hospitalization was from 85 to 92%. And the mortality reduction was greater to 90% with any of the three vaccines. So I think this is something important that we need to transmit this information to other countries. Dr. Iribarren was telling me, look, what happens in Peru in January? Population that's not vaccinated, 350,000, patients with three doses, almost 3 million. However, when you look, not all had three doses. So if you add, there's almost 1,800,000 that didn't receive the full dose. And look at the death rate, 25, almost 26. One dose or two doses was 10 for every 100,000. But those who had three doses was one for every 100,000. So once again, in January of this year in our country, we see the great need to continue vaccinating this population. And look what happened. The tests start to drop. That's one way of following and see what do we see with this third, with a great leap, but only in 10 days. That means that this third wave or fourth wave may be a. Now I'll go back to SINADEF. These are the results of SINADEF by age, mor- mortality according to age, as you can see. Look at what happens with the elderly in the third wave. While there was a good response and it was above the expected, the children, some cases, adolescents, the economically active population, but the elderly over the age of 60 had a peak as high or even higher than in the second wave. So the third wave, there were more people, elderly people who died. However, in Peru, the vaccination rate started to reduce significantly because people thought that they should not continue vaccinating because having COVID had protected them. So it is important that we, as health personnel, provide trust, explain the risk of being compliant, and what is the convenience. When should I vaccinate it? How soon? So one of the things that we have discussed is the role of children. And children also transmit in similar fashion as adults, and the amount of virus is the same as the adolescents and adults. So the grandchildren can be transmitted to their grandparents, and the answer is yes. Well, people are saying that we should not vaccinate children, and they say myocarditis, but not, today we know that 7 per 1 million people. However, the rate of this severe inflammatory syndrome, similar to Kawasaki disease, occurs in 25 of a million people who are not vaccinated. So that myocarditis, which is self-limited, is much less frequent than the injury in those not vaccinated. Children can go back to their usual activities, school activities, but in addition, there's another situation that we need to consider. Important situation. When you vaccinate only adults and adolescents, this is the number of people who died by age group, already over the age of 60 are here. When you vaccinate adults, but all the adolescents, the cases start to decrease. But when you vaccinate adults, adolescents, and children, the COVID cases reduce significantly, and this also seen in the number of people who died. So in that same population, if you only vaccinate adults and adolescents at risk with this, when you vaccinate adults and all adolescents, there's a reduction. And when you vaccinate adults, adolescent children, the decrease is even further. So there's a clear indication to vaccinate children, and the answer is yes. These are the reasons why they argued 200 years ago why we shouldn't use anti-vax vaccine. Yeah, it's not effective, not safe. And many times in Peru, we see people, these are experimental vaccines, they produce more harm than benefit. The adverse effects are very frequent. They decrease my defenses. I had COVID, I don't require a new dose. My religion prevents me from vaccinating. I'm strong, I don't have any risk. All of these are not strong arguments. None of this is true, and it's not a reason not to be vaccinated. And here I will mention what Eugenio Villar wrote about how we had inequity for the, with the poor. Nobody is safe until we're all safe because we're going to see new variants in Peru, India, or Africa. And that the number of children that were orphans is 1%. This is a severe situation. Now, I would like to talk on something in addition. Today, we're very sad to see the major damage of post long COVID. This is a new disease. COVID is over, but they had some lung injury. Many people have depression. They stop working. I saw an international economic report of the amount of people who stopped working after COVID was issued yesterday. So the economy is affected, the personal life is affected. They don't sleep well, etc. And today we know that those who are vaccinated has a significant reduction of this long COVID syndrome. That when is significant. So if we'd like to summary, I must say that vaccines have clearly overcome our expectations. They reduce post-COVID damage and reduce viral excretion. These are sufficient arguments. The problem is that we don't have an efficient and constant distribution in, especially in poor countries, and any doubt, hesitation of the vaccine during a pandemic is something serious to consider. In addition, the variants may affect the efficacy of the vaccine. Therefore, we should have control and remember this consideration. SARS is not going to disappear. The elderly have a high risk of dying. Vaccine is the most effective preventive measure. With having the population completely vaccinated, we reduce the emergence of variants. Finally, all the population should have at least 3 doses, and all those at the risk group should have a fourth dose. This is somewhat the summary that I wanted to comment to try to discuss what we do as an important element So
sobre esto, ¿no?
this is something important to mention.
Ah, así que yo
So
quiero terminar esta
I would
parte
like to finish this part
con este resumen. Sé
with
que
this summary.
pueden abrir
I know
preguntas
we're going to have a
y
question and
yo estoy
answer,
dispuesto
and
a
I'm
responder así
ready
como
to
me
respond
pueden mandar por correo
or
también
send it via email with
Dr.
Dr.
Kai,
Bengolea and Dr.
puedo
Kai. We
responder por
can
escrito.
send written answers to those.
Así que con eso yo cierro esta
So
primera
I will
parte
close this
y vamos
first
a
part,
pasar a
and
dar
I will
rápidamente unos tips
quickly
sobre
talk
cómo
about
remediar,
avian
si
flu
se me permite.
if you
Adelante, doctor.
agree. Go ahead, doctor.
Ya, de nuevo voy a compartir. eh, Uno puede saber la edad de las personas, cuánta habilidad tienen para... no sé si se están viendo el slide.
Perfectamente bien y en modo
Yes.
presentación. Excelente. Adelante, doctor.
Go ahead, doctor.
Perfecto, gracias. Ahora rápidamente,
Now, very quickly, we will
digamos, hay frente a una
present.
pandemia,
When we face a
como la
pandemic,
pandemia COVID nos ha
like the
mostrado,
COVID pandemic,
que
we
debemos
have two things
preocuparnos
that, in
por lo
addition to concern,
menos, primero
are
por el COVID,
distracting us. First, it
la
was
figura cínica
the
y luego el cólera,
monkeypox,
y ahora aparece
and now
el
we
tema de
have
la gripe aviar.
this avian
Por lo
flu.
tanto, este es un tema
Of course, this
fundamentalmente
is a very
veterinario, o sea,
important, it is a
hay que
significantly
es
veterinary
por
problem.
eso que
We
el
need to
sistema de
learn
salud tiene que
that
ser
the health system needs to be multidisciplinary.
ocurre en los
This is
animales.
a pandemic that occurs in animals. And what I'm going to do is to do a
Lo que nos
quick
pasa al
summary
servicio humano,
of
porque
what happens to
digamos
humans,
la influenza, así como
because
tenemos
the
la
influenza
época de la gripe española y el
and the
espanto
Spanish flu
en
and
Hong Kong y todo esto que
Hong
pasó
Kong flu
en los últimos 100 años,
in the last 100 years,
digamos, los animales también tienen eso.
the
Entonces,
animals also have this. So
considero que cuando se habla de influenza,
when we talk
siempre
about
se tiene que ser
influenza,
advertido
WHO
que
has
la naturaleza de
warned
pandemias tiene que ver con
that
esto.
the nature of pandemic has to do with this respiratory
Desafortunadamente,
infection
no sabemos cuándo
where
viene
we
la
don't know
próxima pandemia
when we're going to have the
y hay que
next pandemic.
prepararse y
We
por lo
don't have
tanto
an
tenemos que estar
instrument, and
preparados.
therefore we need to be
Se dice.
prepared.
Y se reconoce que la vacunación es
And
la mejor
recognize that
intervención
vaccination is the most
para
efficacious
evitar
intervention to reduce
y morbilidad
mortality and
de la
morbidity
influenza.
of
Podemos ver esta
seasonal
infografía
influenza.
que muestra
Influenza is a
que
debilitating disease,
se
produces
reconoce que hay
pandemics.
500,000 muertos por
There are
año
500,000
y
deaths per
normalmente
year,
tiene
and
diversos
there are
factores el
several
virus de influenza.
elements of this
Y este es un
virus.
resumen de lo que decía.
And this is a
La siguiente
summary.
epidemia es
The next
inevitable
epidemic
pero no
is
suficientemente
unavoidable but not
prevenida,
necessarily imminent.
que actualmente los cambios de múltiples genes
The
que generan
changes in
patógenos
several
pueden
genes
desviar a
generate
estos.
the avian strain,
Los seres
current
humanos
one.
no tienen inmunidad contra
Humans
nuevas
do not have
cepas.
immunity for new
Probablemente la
strains.
diseminación mundial
Perhaps that the
ocurra en
world
2 o 3 meses.
dissemination occurs in 2 to 3 months.
Vacuna va a ser un problema al
The
comienzo
availability of
y
vaccines is
la
going to be a problem
mortalidad
at the
será muy
beginning,
importante.
and
En la
mortality is going to
influenza
be significantly affected because in the case of
en
avian flu,
2003,
in
todos los medicamentos
2003,
contra la influenza
all the
estaban
drugs that
prohibidos.
were used
Para ese momento no
didn't
había
work.
patentes para eso, ¿no?
There was a resistance to all those
Entonces se había
drugs.
probado los inhibidores
And
de
they tested
neuraminidasa y
the
no funcionaban
neuraminidase inhibitors,
para la influenza que reducen un poco la
and
neumonía,
they
reducen
may
las
reduce
hospitalizaciones,
hospitalizations and pneumonia,
pero no tenían
but
eficacia.
they didn't work
Recientemente,
on
por ejemplo,
avian
ha
flu.
habido
There's been a
antivirales
recent
que
antiviral
atacan
that has the
muchos
advantage that
cambios de
produces
sustancias
several significant
y
changes
por eso tiene una alta eficacia
and has highly
con
efficacious
una sola
and
dosis.
is used with a single dose.
Entonces, no sabemos si esta droga
We don't know if
es
this drug
efectiva.
is going to be effective for avian
Se han
flu
hecho algunos estudios en
because
animales, pero
there's been
posiblemente
very
no
few
tengan los
studies in
efectos
animals, but all the
esperados
avian
para estas dos drogas
flu
que
viruses need to be tested
pudiéramos
to
usar.
see if at some point we could be able to use them. I'm speaking about
Aprobada que sirve para gripe
this
humana.
has approved for human
El año 2009
flu.
aparece
In
un virus
2009,
que aparece
there
en
was an
Estados Unidos
outbreak in the
que
US.
erróneamente le llaman gripe
It is
porcina.
called the
Sin embargo, se
um,
reconoce que
swine
es
flu, but this is H1N1 that had this radical from the swine, but the swine didn't have to do anything with this condition. The other thing that I would like to mention that influenza has a number of outbreaks in the north, and it's different from the south. And how do we prepare the vaccine for the coming years with the tail of this year? So up to 2009, every year, this was the strategy. The tail of this year was a new bug. So we have Peru 21. This is going to be used for the next one. So there was a vaccine for that. In the north, it's different from the south. In 2009, there was H1N1 that's still not gone away. In 2013, we started influenza B, and in 2016, there was a second lineage of B. That's why we have up to 4 viruses. Something that we learned with H1N1, and we oppose strongly against this. They say people that are going to get vaccinated with this vaccine needs a medical prescription. That was a great mistake because people cannot wait for a consultation. Can you imagine the system required to vaccinate 20 Peruvians that needed a prescription? The experience is that that is not the case. Once you do decide to vaccinate, it's the state's responsibility, and all their experts say, okay, this is the vaccine. We should not put any limitations or obstacles or prescriptions. This goes against health. That's why it was considered as an experimental vaccine, and less than 50% physicians vaccinated at that time. The other thing that we learned is that there are risk groups. When we started to learn that in Peru, the risk groups were obesity, hypertension, but there were two important groups, Down syndrome and pregnant women. These were the groups at risk. So the question at that moment was, this pandemic is going to be serious, severe, as such as the avian flu of 50%, or like the SARS-1 and the SARS from the Arab world with high mortality. So they found a protein that's the best marker for pathogenicity. It's not present. And that's important because H5N1, which is avian flu, has the disadvantage of causing severe disease. People has no immunity, but has a very elevated mortality. The only advantage, there's no transmission between humans with avian flu. So this is an important topic compared to H1N1, the so-called swine flu. So it is important for you to remember that we have this natural cycle, that these migrant birds, they go to domestic birds and some mammals, and they may affect human beings. This we know. The first consideration that all animals have flu. It's just a different virus. So all these animals also die. They have a low pathogenicity virus and occasionally high pathogenicity viruses. This is what the veterinary monitor, and we need to respect the system they have. But where there's more option isn't the transmission from wild birds, and that may transmit to domestic birds, poultry. This is a very critical point because this is a group of animals that is closer to the human being, similar to the swine. So this is what we need to remember. So the virus are produced by fragments from each epidemic. The 1918, the Asian flu corresponds to fragments that get together and develop this condition, and you can use a subtype using hemagglutinin subtype or neuraminidase subtype. as you can see, are 10.
Entonces, la gripe porcina, así más
So
bien
the
llamada,
swine flu
sería una mezcla de
was a mix
fragmentos
of
de
fragments
virus, de tal manera que
of
podría
viruses, so
afectar al ser
they
humano.
may affect the human being.
Cuando comienza el 2003,
In
a mediados de ese
2003, when we start
episodio,
to look at these
sucedía en Europa.
episodes,
Esto es lo que pasaba
this is
en
what we
Europa,
saw
en
in
Europa,
Europe
porque
and
había una
Asia,
circulación así.
because there
No
was
se
a
generaba
circulation
mucha
in this manner
circulación,
that ended up in the
no había
US.
mucha circulación
There was not
hacia,
many
hacia el sur.
circulation to the
Entonces,
south.
cuando uno mira cómo ha
So
sido la
when you
estadística
see
mundial
the
en
avian
esta
flu
publicación hecha
with
en
this
el
publication made in 2017,
había porcentajes de
included
gripes aviares
percentage
que
of this avian
México
flu
muchas
where
veces
Mexico
tenía contacto con las
had contact
aerolíneas,
with
pero
Canadian
teníamos
birds,
también
but
influenza,
in Peru we had avian
cepas
flu,
que tenían baja
but
patogenicidad.
with low
Esto es muy
pathogenicity.
crítico para
This is
saber.
critical to
Esto tiene
understand,
que ver,
and
SENASA
this
hizo
has
un
to do.
magnífico estudio
SENASA did a
de
wonderful study
monitorear qué pájaros
of
venían
monitoring
del
what
hemisferio
birds
del
can
norte
come
que
from,
originaban
bring us from the north
y por eso es que
with
existe una
specific
cadena
diseases
de
that Dr.
inmunidad,
Calles
qué es lo que
clearly
pasa
stated
entre nosotros y
that
cuáles son las
what
aves.
are the
En Perú, los
birds
pelícanos han sido
in Peru, the
el grupo
pelicans
más
have
afectado.
been the most affected group.
Entonces, también cuando se estudia
And when you
trabajadores del campo para
study
saber si tienen
poultry workers
anticuerpos
to see if they have
contra la gripe
antibodies
aviar,
against
se
avian
vio que
flu,
ellos tenían el mismo
it was
nivel de
found that they have
protección
the same level
pero no
of
expuestos.
people exposed or
Therefore,
unexposed.
en centros
Therefore, in
donde sacrifican
areas or
pollos
centers
o que son
where
fábricas de huevos, etcétera, no
they
había un riesgo cuando
grow
habían
poultry, there was no risk.
bioseguridad. Entonces, esto era importante porque cada vez
And
se
this was
empieza a
important
reconocer de que la
because
gripe
we
aviar
start to
se
recognize
transmite
that
por
avian
aire.
flu may be
Y era
transmitted to the
conocido
human being.
que existían
And it was
algunos
known that there
casos
were
de
some
una
data
persona
from
que
some
había
people
tenido
who
gripe
have
aviar
had
tanto en
avian
Inglaterra
flu
como en Hong
in the
Kong,
UK or
en
Hong
países
Kong
del Asia,
and in some Asian
incluido
countries
Canadá y
and
aquí.
in Canada
Y
and
todos ellos,
Egypt.
por ejemplo, ahora,
And now
toda esta gripe que ha
all
habido
these flu
de Canadá, Estados Unidos
from
hasta Chile,
Canada, US to
han
Chile,
habido
there's
millones
been
de aves fallecidas
of
y
millions
solamente
of
tenemos
deceased birds
algunos seres
and
humanos
only one
fallecidos
case of a
en el
human
mundo
being in the US
y que
that
han
was
tenido
infected
la lesión de gripe aviar.
and has
Esto es para
this
que vean la
diagnosis.
proporción que había en
And here you
México en el
see
año
what
2005, cuántos casos
we
había.
saw in
Como ustedes ven, no hay
2005,
muchos casos,
and were not
no
very
son
many
muy
cases
similares de manera importante frente al mapa
as
enorme de
compared to the millions
millones
of
que se ven
birds,
con la
and this has
patogenicidad.
to do with the
Esto es
pathogenicity.
sumamente importante. Los
This is
europeos, por
important.
supuesto,
The
van a
Europeans,
vigilar
of course,
todos los
are
casos.
monitoring
Y aquí, por ejemplo,
everything,
este es un
and
sistema
this is a
de pájaros que ellos controlan todo
system
el tiempo.
for avian
Y ven
influenza,
en determinados
and you see
días
how
como un brote extenso y después
they see an
desaparece.
extensive outbreak and then disappears.
Aquí de promedio pues no hay vacunas y no ha
There are
habido
no
una gran
vaccines.
historia de gripe. Como digo, es importante. La mortalidad,
The
recordar que va desde el
mortality, we
30
need
hasta
to
el
remember that
70%.
goes from 30 to
Y esta
100%.
probablemente es la cifra más
And this is
notable.
perhaps the most
Ustedes
remarkable
en la OMS en
figure.
los primeros
This is
años, los 4
WHO
años
in
vimos
2004,
que
2005,
los 4 países
where
que
we saw
eran
the
que
four
tenían
countries that
picos
had
eran
more
China
cases.
y donde ustedes ven al
China
final
is
el
missing
número de
here.
casos
When you see that the number of
112,
cases were
actualmente son
112, we
850.
have
¿Y cuántos
850 at
años han
present.
vivido?
How
50
many
años. O
died?
sea, la mortalidad
57. So
estaba alrededor del
mortality was
50%
around
en México y se
50%.
sigue manteniendo.
That's
A
still
diferencia
the
de que
same.
un
The
caso
difference is that
de influenza aviar
one
no
case
se
of avian
transmite entre
flu
seres humanos.
is not
Esto
transmitted
aquí
between
es
human
una
beings,
situación muy
which
importante
is something
y
very
muy
important.
importante. O sea, hay una transmisión
There is a
de los
transmission
pájaros
from
hacia
birds
los animales domésticos y
to
hacia los
domestic
humanos,
birds and to
y es
human
una
being,
tasa muy baja.
but it's a very
Esto
low
puede
rate that
decir
is
que
not transmitted from one human being to another human
desde
being.
el punto de vista clínico es muy
And from the
parecido.
clinical
No hay
point of
mucha
view, so they're
diferencia.
very similar. There are no
Hoy en
differences.
día,
So
lo
nowadays,
importante es que el cuadro clínico
the clinical
es muy
presentation
distinto, por
is
eso
very
comienza
similar at the
rápida
beginning, but there
y muy
has
rápida de forma severa que los
uh,
pacientes entran
rapidly
en
goes to severe cases and patients
complicaciones
present
de manera severa.
respiratory distress and have
Simplemente quisiera hacer
early
dos
death.
consideraciones
So
generales.
general considerations to conclude. This is a new situation of a transmission rate to human that is exceptionally low. Only 30 to 40 annual cases are reported in the world. There is no transmission between human beings. Human cases are young who are in very close contact and continuous with birds in the in Southeast Asia. And the transmission will depend if it's high pathogenicity or low pathogenicity influenza. H5N1 that's circulating at present has high pathogenicity. There's no health staff that has been infected. We haven't seen that. The clinical presentation is very similar to other respiratory viruses, but have a rapid clinical deterioration. So transmission occurs with contact of infected bird or recently dead, where the blood and all products may transmit the disease, but that's intense and continue contact. The health personnel should manipulate using gloves and face mask. There is no transmission by eating birds or eggs of becoming infected. The answer is no. And I would like to insist on this because social networks and that can affect the economy. Peru consumes a lot of chicken, and it would be a catastrophe to provide incorrect messages. And that's the same for all the Andean countries. We don't have a vaccine for this virus and neither for birds. So prevention needs to use gloves and face masks in situations of risk and the non-qualified. So the population should not manipulate these birds. You should call the municipality and they should quickly deal with these animals and bury them as soon as possible. Perhaps it's going to be important to see if there's any resistance to antivirals. We don't know that yet, but we need to consider this in case that there was a clinical case. But I think that this is going to be extremely rare. There are millions of infected birds with this high pathogenicity virus and only one case in the US with this condition. So to close beaches is not a good time for countries. It's not adequate. The management of these animals should be done by technicians from the animal health. But so what we should emphasize that this is an enormous effort from the veterinary sector and the government have to support the national systems of veterinary medicine for a strict monitoring, similar to what we do in human beings with influenza that has to also be done with this condition. So this is what I wanted to mention of this topic and mention these aspects that I think are important and to bring this to discussion because we can create myth in a moment where the COVID-19 pandemic is not over. We need to be very careful that our information is adequately transmitted, that there are no incorrect information being spread. So I will conclude, and I'm sure there's a lot of questions. Once again, I would just like to emphasize that governments need to strengthen the concept of One Health and that surveillance at this moment for these animals and other animals. It's as important as the monitoring we do for humans because the future pandemics are going to come from animals to human beings. So we need to do this monitoring. But this avian flu is very important from the veterinary medicine, but has a very small impact in human beings. And I would like to emphasize that because we still need to put our emphasis in COVID-19 and in reducing the impact of COVID by vaccinating the population so the non-COVID children can be vaccinated, the adults receive their vaccines for pneumonia, that the cancer population have early diagnosis, that the patient with diabetes has a continuous support, children have their vaccination schedule with no diphtheria or polio because we stopped vaccinating. And for that, we need to redo our health system by reducing the impact of COVID. Of course, we need to continue monitoring, but we need to pay attention to the areas of high priority. And with that, I finish, Dr. Bengolea, and I thank you very much for the time you've given me. And unfortunately, we regret that Dr. Ibarra is not here, specialist in hematology, graduated from San Marcos University, person dedicated to technology and to strengthen a deaf. Thank you. And I'm here available for any questions. Thank you, Dr. Eduardo Botuso. We value all the information that you have provided to us in order to have a clear understanding of the value of the National Informatics System for deaths. And in this task that's so important, this is a crusade to recover the system. Dr. Juan Luis Iribarren had all the analysis and scientific studies to demonstrate how valuable is this institution for public health measures, and also to contribute that for generations can start doing research from this information of having access by not only from the academic centers, but also people who want to study the causes of death. It is important to highlight in this topic, and this is a commitment of our institution, to continue with this effort in order to collect information from national scientifics and technicians to recover this valuable working tool for the identification of deaths in our country. On the other hand, you have mentioned, speaking about vaccines, there are several important information for our community. Among them, you have scientifically demonstrated with data from research about the important relation of vaccinating people and protection for the most vulnerable groups. You mentioned the enormous impact with pregnant women who were affected before the vaccine, with a number of issues with ICU admission, intubation, maternal death, child death. But following the immunizations in Peru, we were one of the first 5 countries who started this vaccination and came down to 0 death in pregnant women. And the gestational state doesn't prevent being vaccinated and protected her and the child. Another important topic that you told us is related to the impact of vaccinated the adolescents and the adults and the elderly. The more vaccination coverage we have in these groups, we will have a lower risk for transmission and lower the risk of death. You have demonstrated that there are vaccines that have been used throughout the world, and all of them have a significant role. And despite some questioning, but it's been scientifically demonstrated that vaccines were useful to prevent death in several groups. Another important that has you that you have shown us is related to the actions that need to be taken jointly to be able to have a vaccine coverage in populations who are susceptible. And another topic that we consider of high relevance is that with the emergence of a new variant, with Omicron, there are subvariants that don't produce cross protection against the disease. So if somebody gets ill, it can be reinfection by other variants. This is something that we should all take into consideration and complete the vaccination. And to not to extend in my comment, in the summary, you've mentioned avian flu as one of the problems that are affecting the world. And we've seen outbreaks in migrating birds and marine birds in Colombia, Ecuador, Peru, and that the rest of the continent is increasing their measures to see that this doesn't affect the poultry. There's been some outbreaks, but they've been controlled adequately and quickly. And at this moment, it's affecting only birds. And something that you also mentioned is that avian flu is not going to produce an epidemic in humans. It's just an occasional infection in those who have very close contact with birds or touch them. And therefore, your recommendation to avoid touching birds, marine birds, only for specialized staff who's adequately managed and get rid of those dead animals. And finally, we would like to highlight that in the final message, one of the consequences of this information is that we should protect ourselves with vaccines, that we need to protect the child, the adolescent, the young, the adult, and the elderly. That's the best way to avoid the problem that you mentioned, which is long COVID or this disease produced by COVID after having the acute disease. And not necessarily with severe forms, but also with mild forms. At this moment, we have a large number of questions, all very interesting, and I would like to share them with you. The first question is the compliance of preventive measures against COVID was significant in Peru until the start of 2022. Then the public standards were relaxed and there was some neglect. And what strategies should we take in this critical situation? Go ahead, doctor. The two measures. The first measure that is clearly being demonstrated, the use of face masks in public areas are required. Today, many countries in planes and in public transportation with large groups. That is one of the reasons why in Europe, when you look at the European maps, you see a remarkable number of waves. And that's because in Europe, there's no mandatory use of face masks. I think that face masks are a use of a mask is a protection system. It's not perfect, but it does help and reduces. And we know that when there were no vaccines available, that people who acquired COVID with mask, that's a different presentation. So the use of mask is an important element. I think what was exaggerated was the cleaning. There were a lot of investments in the use of substances when we know that the transmission is almost zero. There are viruses in the surfaces, but the transmission is not significant. So the use of masks is still important in areas where they're public. What happens is that people are not obligated to do that, but we've lost the sensation that there's no risk. So people don't wear a mask. And I think that those are the two actions that I would recommend. Use mask in closed areas. In the open spaces, emission is almost zero. That is why when people say beaches, the beach, the same as hot areas, the transmission is easier when there is an activity in closed spaces with several people. So but the other measure is to get vaccinated. The vaccine clearly reduces transmission, and if you get ill, you have less virus. We know that the first day, vaccinated and not vaccinated have the same number of virus, but on the third day, the amount of viruses in the vaccinated is much lower. On the fifth day, almost 98% of vaccinated don't have active viruses. And that is something that we see with the unvaccinated. So the vaccine clearly has an important role in the family transmission. There's less family transmission with vaccinated. So these are the two recommendations. The next question. Many of the Pfizer vaccines offered at present have expiration dates of October and November. Is it safe to use them? That's a complex question. The other day, somebody asked me, what would you recommend? First thing that I would recommend is to ask the companies the authorization to know, because the expiration date has to do with international standards. You cannot extend more than 2 years, but after 2 years, the vaccines are still efficacious. What happened along the way is that some medicines that produce some harm, and that was over-dimensioned. What I will say is that ask the opinion of the manufacturers if you can extend that date. I have the impression that you can do that, but this is a personal view. The vaccine is not going on the day 30 is used. There may be less efficacy or some adverse effect but it was not studied as such. So from that point of view, I would recommend that the state ask the companies that are manufacturing if there can be an extension of 3 or 6 months so we can use them, because people are not getting vaccinated and those vaccines are expiring. It's something difficult to understand in a country with these economic conditions. So I would recommend to discuss it with a manufacturer. And this is my personal view, that a vaccine doesn't lose efficacy the day after they expire. So it may be used as an emergency situation. But with a pandemic, I would suggest to have more information of the manufacturers themselves. Thank you. The next question, how frequently should we vaccinate against COVID-19? This is a difficult question because while your antibodies continue to drop, you lose efficacy. So the immunosuppressed people, which includes those over the age of 65 or could have some comorbidity, in 6 to 8 months they should receive a booster. Now, many people who vaccinated in January, they are presenting COVID. Fortunately, it's a mild COVID, so there's still antibodies, but they are not fully protected, especially those immunosuppressed. Again, there's not much information. We know that these antibodies starts to decrease, but the antibodies is one of the areas of your defense mechanisms. The other ones are based on your T cells, and T cells cannot be measured easily. So the antibodies, we do know that when they start decreasing, you lose the efficacy. And every variant, unfortunately, it generates a different response. So I would say that a high risk person, I would recommend every 6 to 8 months to have a booster. And the answer is yes. Thank you. It's a question about the last topic that you mentioned. Is there any relationship between avian flu and agro-industry or livestock industry? What standards should we have or regulations from the approach from One Health? Well, the first thing that I can say is that we need to put economic emphasis in supporting institutions like SENASA or animal health systems, because the zoonosis represent almost 40 to 60% of emergent diseases in the world. So we need to work together. And for that, we need to monitor, like we monitor the causes of diarrhea and respiratory infection. We also need to monitor animals. So the first thing that I will do is to strengthen the surveillance and monitoring of animal health. All the animals have flu, similar to human beings, but that's a flu with low pathogenicity. When we see influenza in animals that have high pathogenicity, many animals died, but has no relationship to the industry. On the contrary, the industry, you've seen the information that the staff don't get infected. So every now and then, in an unexpected way, we see influenza virus are more pathogenic in animals, and that circulates in the north because the birds migrate like that. For Latin America, we have very few birds that come from Canada, where they end their migratory cycle. Some of them can bring some disease, but the risk is much moderate to what we see in Europe and in Asia and the US and Canada. But our veterinarians should always be alert, and that is what I will recommend as critical to understand the concept of One Health. Well, we are very thankful for your wonderful presentation and the recommendations for public health that need to be followed by our population and authorities. I would like to thank all the attendees who are present at this moment from different countries, from the Ministry of Health of Bolivia, Chile, Colombia, Ecuador, Peru, Venezuela, of the National Institute of Health of Peru, for the Roundtable Against Poverty in Peru, to the branch of Abancay, Direza Lima, countries such as Argentina, Bolivia, Chile, Colombia, Ecuador, US, Guatemala, Mexico, Paraguay, Peru, and Venezuela, who have kindly joined this meeting. We appreciate, Doctor, and the doors are open for a second occasion with Dr. Juan Luis, to talk about this special topic that are going to strengthen in the recovery of SINADEF. Now the final words for Dr. Maria del Carmen Calle, Executive Secretary of the Andean Health Organization. Thank you very much, Eduardo, for your presentation. I think that everyone that has listened to you in that regard, perhaps the bivalent vaccines will arrive in January. We have been discussing with the immunization office, and definitely it will be first for those who are in the first line, or the people with health, for the elderly, and for those who have comorbidities. This has been extremely clear in cancer, which is something that many people ask, in pregnant women, even those renal patients. I think that those populations that you ask you, and you should be clear in your answer. On the other hand, you've given importance to all the vaccines. All the vaccines have decreased hospitalization and death, and that should be clearly stated. And it should be clear that there's higher coverage with Moderna. The first dose is with Moderna, so that only Pfizer or not believing in the Chinese vaccines. I remember what's the best vaccine, the one that's close to your shoulder. And I would like to recognize all the effort of the Ministry of Health. People are asking and wanting to vaccinate you because they have teams all over the places, and to the population, to the community. We know that the vaccination is extremely important. That also, we should also remember that we need to wash our hands and use face masks in places where there's a lot of people. Another important topic has been this SINADEF. From the Andean Health Organization, we have been, our responsibility is to contribute and defend health and well-being. So while, as long as we can promote discussion spaces where things are done better, we will be there. So this SINADEF, Juan Luis is ill, but we will be able to have him in a future webinar. I would also like to tell you that there's been technical meetings with the Ministry of Health, with the presence of Dr. Gotuso, Dr. Iribarren. We thank Lucho for coordinating. So we are alert. Today is webinar 153. We're closing the year with 2 more webinars, 255. And if you remember the first webinar that we did in May, the topic was precisely everything that had to do with COVID. But Eduardo has mentioned everything what he's mentioned is important. I just rescued some of them. I like this, that we need to get vaccinated. When there's someone ill, they should stay at home. Why? Because we are using health services and we're having people that have other issues and cannot be treated. We need to improve the coverage in children's vaccination also. You mentioned cancer, AIDS, tuberculosis are being set aside because of COVID. You also mentioned the orphans. We, from our institutions, we are talking about this for months, so that they're issuing a publication of the Social Pediatric Committee of the Latin American Association of Pediatrics and the US and PAHO about the syndemic in our population, and the only country that emphasized the orphans were us, because we're the ones that have more orphans. 1 out of 100 children have lost their mother, their father, or both, or their grandparents or both, caretaker, or we're talking about, if I'm not correct, more than 170,000 people. We're not talking about a small number of people. And we're working with the Ministry of Health in uh, how are we going to support the new orphans, but also the new parents, those who are going to take care of these children, with the idea that after the grief is over, this mourning process for COVID is much longer than the regular mourning process, and see how can we support. On the other hand, you mentioned a very important topic that we've talked about it a couple of times, the long COVID. And the truth is that, Eduardo, we've had meetings with national health authorities of the 6 countries to see what we're doing. Because let's be honest, that implies an investment. Because the numbers are not exact, but we're talking about 10 to 20% who have this problem, this issue. And thank you for mentioning the vaccines that decreases that chance to get this long COVID. So I would like to mention avian flu. The contact are minimal, but of course, we people who are in contact with birds have, this is a veterinary problem. This is more a veterinary issue, but we also want to think the possibility of listening Dr. Gotuso, because he gives us an update. And one of the first things he mentioned is the pandemic is still on, not over. As an example, the sixth wave in Spain and the other one in Germany. Remember that we are a mirror. What happens in Europe and the US comes to us. So this is not only uh, forget that we are in this pandemic, because the numbers are clear, there are more and more cases, and we do know that there's a lot of under registration because one has COVID at home and only one does the test, and only one does the test at home. So thank you so much, Eduardo, Lucho, to all participants, to all the group of the Andean Health Organization that made this possible, to come to webinar 153. This is a week with 3 webinars because we didn't want. Tomorrow we'll talk about human rights, because on the 10th we're celebrating the Human Rights Convention. And tomorrow we're going to have recognized speakers. And on Thursday, we're going to talk about sexual diversity. So we invite you tomorrow and the day after tomorrow to these webinars, that these are going to be in the afternoon at 5 p.m. Tomorrow, Wednesday, that we never have a webinar, this is going to be a very special occasion, and both of them at 5 p.m. Lima time. Remember that we can see www.horascono.org. This is what gives us more satisfaction. There is a lot of information about what we're doing. And I would like to take this opportunity to thank for all that you write and tell us. Thank you so much. Don't worry, next year we will continue with the updating. And there's so many topics that we need to consider. But we need to remember that we contribute to increase the health and well-being of the population of the 6 countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. Because we're completely convinced that Together we are stronger, and together we will reach further. Good afternoon.
Gracias.